And so here we have a lady, a patient of mine. I didn't see her for years. She just started coming back like 2 weeks ago. Gained about, 75, 100 pounds. She had a very, I don't even know, it's happened way before I met her, but apparently an extremely severe case of Bell's palsy that did not recover. And I actually did investigate a little further, and we found nothing, so it probably was just a case of Bell's palsy that she didn't recover from. Now, if you were to just look at her and meet her and say, "Hi, Ginny," you may not notice the facial asymmetry that much, although to the trained observer, it's pretty apparent in the mouth. Right there. Gotta have all this. Now I'll tell her to look up. So what are you looking for when she looks up is wrinkling of the forehead and elevation of the eyebrow. Look how clear that is, that her right face can do it. Now, by the way, does her eyelid elevate? Yeah, why? Levator palpebrae. This is in the 7th nerve innervated muscle. So I remember having somebody call me and say, "I think my patient is malingering," because I had them look up. I remember your class, and I had them look up, and their eyelid went up. And I said, that was the part of the class you turned away for. So you can see here, look at that eyebrow elevation, clear as a bell, and the forehead wrinkling. Also, you can actually see it in the upper eyelid a little bit, but I think here I was just showing how we do have normal elevation of the eyelids. Then I ask her to close her eyes. So look up. Remember I said we want to test the upper part, the middle part, the lower part of the face. So look up is an upper face test. Eyebrows, forehead. Then you tell them close your eyes. And you'll see, I actually have the video of this besides the stills. And you'll see here that when you say to the patient, "Go ahead and close your eyes tight," they'll go like this. Then you have to keep saying it tight, tighter, come on, tighter, tight as you can. If I'm going to try and open them, I can't. Then you get them to actually squinch up or scrunch up, or whatever a good word for that is, their entire face. And then you can see some things very clearly. One of the things to look for is how much eyelashes can you see. If a person really scrunches their face, you may see none or a tiny bit. If their eyes only closed a little bit, you'll see a lot of eyelashes. So again, you can see even at this distance, and with this arrow in the way, that we see eyelash here, none on this side. Then you look at what we call the nasolabial fold, the fold of skin between the nose and the cheeks. I guess nasolabial, you'd think it'd be down here. This nasolabial fold is obviously asymmetrical and different from the opposite side. And then you ask her to draw down the corners of her mouth like this. Pull your mouth down, and you can see again her right side is quite paralyzed. Here she is. Oh, this is the video. So let's watch. She actually looks like, I think I did them at a different time. She looks like she's starting to gain some weight there. Okay, now look straight ahead again. Okay, now I want you to close your eyes just as tight as you can. Tight, tight. So tight that if we opened them or tried to open them, we couldn't do it. Good. Okay, now I want you a big smile. Big as you can smile. All right. And last thing I want you to do is pull down the corners of your mouth like you were frowning. There we go. Okay. And look straight ahead again. All right. Again, thank you so much for your time. All right, so we're going to look at the patient for facial asymmetry, and then the movements that we just did in that last video. You gave them, coax them to make full effort. You saw that, so we'll just keep going. Nasolabial folds. This is everything we saw. Here it is on a person that doesn't have facial paralysis, just me showing a previous version. See how the first time she barely closed them until you really coax her, and she still won't crinkle her face. Too unladylike, apparently.
Pull back the corners of your mouth with a huge smile, big as you can. There you go, good. Okay, that's just okay. Why don't you just open your mouth?
This is lower cranial nerves, so we might as well take a peek at them now.
Stick your tongue straight out.
That's 12. Open your mouth is 5. That's 9.
Say again.
Okay. Sort of 9 and 10. So we did 9, 10, 12, and the lateral pterygoids of 5, just with that, 10-second test right there. So on the sensory examination, taste is carried primarily by 7, 9, and 10, but most people say the anterior 2/3 of the tongue is purely 7. In the case of testing for taste, again, I'm not going to get too involved in that, except that it's very important that you have whatever the solution is. Let's say it's sugar water. It's got to be dissolved, obviously, and then painted on the tongue. So the person sticks their tongue out, you take the sugar water, you put it on the end of a little brush, and without them closing their mouth and going, Because then they're just going to smack it all around. You paint it on and ask them to identify. Sweet, salt, those are good ones to use. Otherwise, there's really not a lot of sensory examination. I mentioned that sometimes you have this hyperacusis, meaning sound actually hurts the patient a little because of paralysis of the stapedius muscle. Good way to test that is take the telephone off the wall, hand it to them, and just start, if you probably have a touch tone phone. Any dial-up people out there? If so, you can just quit being a diplomate. But anyway, go ahead and take the phone and just hit a few buttons, and if they go, and then ask them to compare side to side. It's like your little audiometer. And if it's definitely louder in one ear, make sure they sort of cup the phone over the ear, then you probably do have a problem with hyperacusis. And again, if that's related to facial paralysis, that could, that signifies that the lesion is proximal to the stylomastoid foramen, and it could still be Bell's palsy, but you might want to start considering some more ominous diagnoses. Cranial nerve 8, we have 2 divisions to worry about here. We have the cochlear division for hearing, and there's some anatomy there that we'll just zip through because Dr. Dishman is going to kill you with that at a later date. And then we have vestibular division. And the vestibular division, again, has a different anatomy, but essentially they're both carried together. It's almost like cranial nerve 8 is really 2 nerves. They travel together peripherally, but there's not all that much similar to them centrally. So again, these slides are all in your notes. You can spend as much time as you want with them. They're really very, very simple anatomy. You're going to get a much more detailed neurology diplomate level anatomical training from Dr. Dishman. Obviously, the vestibular pathways, we talked about nystagmus and cranial nerve movement and eye movement. And so if the vestibular pathways are necessarily then connected, if you tilt your head or move your head, it changes the position of your eyes. You still have to make sense of that. Another thing actually are the little perturbations. It's interesting. You ever mount a camera on the dashboard of a car and drive, and you'll see it's a constant bumpiness. Yet when you're driving, looking through your eyes, you don't see the bumpiness. And the reason is because literally your eyes, even though your car's bumping, your eyes stay fixed on where they are and they're moving. So those little perturbations, it's all very, very essential that the position of your head at any moment changes the position of your eyes. So those two need to be linked together. They are through the vestibular system, and it's the reason that we get nystagmus, which is, again, the sort of short-circuiting of the frontal eye movement centers and the occipital eye movement centers. So we get the saccadic and the following eye movements from that. Again, even the slightest change in the position of your head will be picked up by the vestibular system and automatically via the kinetic labyrinthine reflex be relayed to your central nervous system. Loss of hearing, I want to cover that a little bit because you can pull a tuning fork out of your kit and you can really do a lot with it. There are 2 varieties of hearing loss. One is neurological, one is not. The more common is the conductive hearing loss, which is not really neurological. And all that means is somewhere between the world out there and your tympanic membrane, there's a block in the transmission of sound. And so that will be called a conduction loss. It's just not conducting the sound any further. So the most common cause is a big pile of cerumen in your ear. Blocks the ear canal, sound can't get through to the tympanic membrane. So you should always do otoscopy. Look in the ear, make sure you can see the tympanic membrane and its pearly gray and little cone of light reflex and so forth to be sure that it's clear in any patient who has a hearing complaint, or if during your neurological exam you detect a hearing complaint. Then you've got the tympanic membrane. Now, the tympanic membrane can actually be torn and then heal with scar tissue, and that would still be a conductive type of loss. Also, over years, people like rock musicians and people that do a lot of shooting or are exposed to very loud noises, factory workers, they can develop tympanosclerosis, a hardening and scarring over of the tympanic membrane, which is another type of conductive hearing loss. You can even have a single episode of a loud sound. Like I remember that, I think it was Geraldo Rivera was doing a special on professional wrestling, and he stuck a microphone in the face of one of the professional wrestlers, and he said, "Isn't this all fake?" And the guy took his giant hand.
John Stossel.
John Stossel, that's who it was. And hit him on the side of the head, and Stossel got up, and he hit him on the other side of the head. And then I read in the paper like 2 weeks later, Stossel had bilateral ruptured tympanic membranes. So again, you cup that air, you get it over the ear, there's no place for it to go, the membrane is only so malleable, it'll tear. Once it tears, it heals, but you heal with scar tissue. Typically that scar tissue is missing the middle layer, the pars tensa, so it becomes more of a useless tympanic membrane. Another type of conduction loss is when the ossicles of the ear become arthritic and they stop moving. So you can have an ankylosis really, and that's where if you were in chiropractic college, they taught you how to adjust the ear. That's really not a bad thing to do to keep those ossicles moving. Believe it or not, they're facet joints. However, we're here to talk about the, also of course you can have otitis media, middle ear disease that just puts so much fluid behind the tympanic membrane that it blocks the vibration of the membrane as well. So all of these are in fact mechanical causes of hearing loss that should be separated from sensorineural causes of hearing loss. So the sensorineural hearing loss, now we're talking either the end organ, the organ of Corti, or in fact the auditory nerve, the eighth cranial nerve. Just mentioning here, presbycusis. Anytime you see presby before something, it just means old people. So presbyopia, vision loss with age. Presbycusis, hearing loss with age, those types of things. In fact, I had an uncle who was director of rehab medicine at NYU, and he asked me one time if I knew the definition of presbyopia. And I said, yeah, it's when the eyes can no longer accommodate for near vision. He goes, nope, wrong. And I said, well, what is it? He goes, it's an abnormal lengthening of the arms. So you can use that anytime, just send me a royalty. He died, so I don't have to pay him. At some point during the history, not a bad little way to test hearing would be to just turn your head or make like you're rubbing your lips and say something in a very soft voice to the patient, see if they heard you. It's just a quick test. You say like, so tell me, when did that begin? And if they go, what? What'd you say? Then they may have been reading your lips to a good extent. And so if they were reading your lips, then obviously they have a hearing problem. And again, if you saw my video earlier where I asked the patient, do you have any difficulty hearing? And she said, I don't think I do, but my kids all say I do. We'll take that as a yes. A very useful quick test, and that's why some of these tests are useful because they're so quick. They're not really the most accurate or best test. It's just something called the finger rustle. So all you're going to do is test the patient's hearing by putting your hand in front of their ear while they're looking at you and just rustling your fingers a little bit and saying, raise your hand if you hear something. You rustle your fingers, they raise the hand on that side, and you've got your hands on both sides, so you do one, the other, they raise the hand, you know after 2 or 3 that they're really hearing something, and that's pretty good. A little finger rustle would be hard to hear if you had any significant hearing loss. But once you've determined that the patient has some sort of a hearing loss, you can go ahead and do a little more refined, reliable testing with a tuning fork, and ultimately you're going to send the patient to an audiologist that'll figure which frequencies of hearing is lost, and that points you in the direction of specific disorders that cause hearing loss. But for hearing, you're going to use the 256 or the 512 hertz tuning fork. And there are 3 tests discussed, of which I think the Weber is by far the most valuable. But again, the Schwabach and the Rene or Rhine test are also usable tests. Remember that often eighth nerve problems, I thought I had a little bit more on the tuning fork, so I think I'll just give you my audio version, and then if there's more coming up, we'll do that. So basically, here's what you do. I know I have some stuff coming up. I take that back. I'm going to go ahead and we'll get to it, I promise. Remember that we also have the eighth nerve has a vestibular component, and the vestibular component, the symptoms of vestibular disease are anxiety. People do not like it when the room is spinning. They get an autonomic response. They tend to not feel very good. But they'll tell you that they see the entire world. All that is, we call it oscillopsia. You see nystagmus, but they're looking through those eyes that are going all over the place, so they see the jerking world. That's called oscillopsia. And I had some last night with drawn butter. It was delicious. I don't know, it sounded so good. Vestibular disease causes unsteadiness, nystagmus, as I mentioned, the autonomic signs. Rarely does the patient fall from vertigo. Usually they just need to lean on a wall or grab something, unlike hemiballismus or things like that, where there's quite a violent flailing of the body and falling down. Pallor, sweating, vomiting, these are all things that accompany vertigo, true vertigo of vestibular origin. because of the autonomic integration. So, of course, we've talked over and over now about observing for nystagmus, extremely important. Anytime a person comes in with a hearing complaint, you want to go right back. Remember, I said earlier about different, but think it through. If a person comes in and they have a hearing complaint, or let's say they have a vertigo complaint, you want to check to see if they have a hearing complaint. If they have a hearing complaint, you want to check to see if they have a vertigo complaint. If the two are together, hearing and vertigo, it's really pointing you toward that peripheral eighth nerve. As you go more centrally, those things split, and you can have more one or the other. So very often in eighth nerve disease, also if you go to the end organs and you just have a disease, for example, of the labyrinth, that's going to cause vertigo. So again, at the end organ we have a split. You can have cochlear hearing problem, end organ problem. You can have a vestibular end organ hearing problem. Then they come into the eighth nerve where you pretty much can have both hearing and vertigo together. And then you move into the central nervous system and they split again, and you can have a dissociation of those two. In the old days, we used to squirt hot or cold water in the patient's ear to see whether or not the eyes developed a normal nystagmus. The logic is if you put hot or cold water in the ear, you could create convection currents within the labyrinth, within the semicircular canals. And those convection currents cause one ear to say I'm moving, the other ear says I'm not moving, and that causes a short circuit, which gives you vertigo. You can predict the vertigo. And the mnemonic was always cows, cold, opposite, warm, same. And when they talk about that, they're talking about the jerk component of the nystagmus. So if you were to put cold water in my right ear, what you would expect is the jerk in the nystagmus that was produced subsequently would be to the left. Cold water causes an opposite jerk nystagmus. Warm water in the ear causes a same side fast jerk nystagmus. And the reason we do it is to look for a normal response. If you put water in the ear, hot or cold, and nothing happens, then there's something obviously wrong. Or if you get an opposite or unusual response. But really it's impractical. This will cause vertigo in the patient and nystagmus. It's uncomfortable. It's very hard to see the jerk, as you saw even from the video zoomed in. So there's something called Frenzel lenses that most chiropractors won't have on hand, but they're big Coke bottle type lenses that you can really magnify, really see the eye. So most of the time we're not doing these caloric irrigation, caloric meaning temperature irrigation of the ear. Instead, the more modern equipment just uses a puff of air, and it's done with the eyes under video observation, and so it's a much more specific, you can really detect. As you saw, that computer was trying to find the center of that pupil, and one of the things that the computers does is they measure the nystagmus, they'll tell you the degree, the speed, and everything else with a true vestibular laboratory, which is a wonderful, these are a great service to provide to people.
We're going to have that instrumentation here for the vestibular module.
Are you really?
Oh yeah, a whole weekend on vestibular.
That's great, I might come to that. I love that stuff. I don't know who you're using, is it Jacob's old company?
No, but it's
Jacob Green?
Jacksonville.
Yeah, Jacksonville, it is, it must be his old, it's a different company though?
It could be, I don't know.
Okay.
Yeah,
That's fabulous. You got to go to that module. What you can really determine central versus peripheral with dead-on accuracy with that equipment, and a number of other things in between. But you can verify, you can measure progress, deterioration of a condition, a lot of good diagnostic clues. It's not the end all. It doesn't. You don't push a button and it spits out a printout of exactly what's wrong with them, but it's pretty damn close. The Dix Hall Pike maneuver is the one that we're as chiropractors probably going to do in our office. Very, very simple. I teach a whole module on diagnosing and treating vertigo. It's a wonderful thing. Every single chiropractor needs to do that, and I'm sure Don will cover that. And the reason I say that is because vertigo is a huge complaint, and the treatment for it, the accepted medical chiropractic treatment for it, is something that doesn't require drugs or surgery. So why wouldn't we be doing it? What it does require is someone that's got a table, someone who's used to positioning a person's head. Well, let's see, maybe chiropractor, huh? So there's about 30 different reasons why this fits wonderfully in a chiropractic practice. To perform the Dix Hall Pike, all you have to do is you have the patient sit on the end of the table, they turn their head looking toward you, and then they lean back so their head goes off the back of the table. As their head is in that extension rotation position, you look to see if they develop nystagmus. If they do, then they probably have a problem with the labyrinth, if it's labyrinthine or semicircular canal related, on the same side that you just turned their head to. So they turn their head to the right, and lay back, they're testing the right semicircular canals and the utricle sacularia. And then also on the left, they're testing the left. When they turn their head, lean back to the left, they're testing the left semicircular canals. And I have a whole bunch of video on that. I don't think it's quite on my website. I'm trying to think where you could get that, because maybe I could upload it or send it over to Don. A whole bunch of me, because I teach that as a separate course, I have a lot of video of me performing those tests. The Schwab test, you're just comparing your hearing to the patient's hearing. Not very scientific. Your hearing has to be normal, of course, or at least you have to know the parameters of your own hearing. So what you do, you take your tuning fork, you tap it, and again, I like to do a reliability check, because with sensory tests, it's not that I think the patients are lying. If you ever watch the show House, he'll tell you patients are lying to you all the time. But I don't think my patients are lying to me. But I recognize that people with neurologic function can't trust their own nervous system. I hate to do asides when we're really in the tail end here. But I had a case of a chiropractic student who was paralyzed from T4 down due to an AV valve. I talked to him for a few seconds about that yesterday. I went to examine him, and I said, I want you to tell me if you feel me touch you. And he was lying on his back looking up, so he couldn't see me. And I said, say now when you feel me touch you. And I touched him, and he said, now. So I thought, oh, good. Then I touched him again, he said, now. Then I was just about to touch him, and he said, now. And I wasn't touching him yet, so then I stopped touching him, and he was going, now. Now. And I said to him, well, where did I touch you? Left ankle. Right big toe. And you see, when your nervous system has been receiving information from your body for the last 30 years, this kid was 24 years, so 24 years, and suddenly it's taken away in an instant, your central nervous system is trying as hard as it can, and it confabulates. And so what happens is, he wound up thinking I was touching him. So it's not that I don't trust him, I want to be sure as I can that these tests are valid. So what I do with the tuning fork is I take the tuning fork, and I not only tap it, put it in front of their ear, but I tap it and put it in front of their ear, and I say, do you hear any sound, any buzzing? And they'll say, oh yeah, yeah. I say, tell me when that stops. Then I take my other hand and I stop it. And I want them to tell me within about 2 seconds it stopped. Then I tap it again. Well, they wouldn't know exactly when it stopped unless they understood exactly what their instructions were, and also actually were hearing the buzzing. So now I know, now they can still lie. They can say, yeah, Shay, I don't hear nothing, Shay. But that's not what the test is for. At least we know they understand. Then I tap it again, and remember, try and be mechanical in how you tap it. It's got to be the same every single time, because over a period of time it will be. You'll just get used to doing that. You hold it at the node. That is where the two come together. You hold it right there, you hit it on your palm, and you just get good at that. If you hold it on one of the forks, of course, it stops the vibration. And so you tap it, you hold it in front of their ear, and they tell you when it stops. Then what I do is I quickly run it back and listen to about how much and how far it is from my ear, and I compare my hearing to theirs. And that's all there is. I do it right side and left side. The Rene test or Rhine test is where you're comparing bone conduction to air conduction, and I want to be honest with you, it's not all that useful, so let's just put it this way. They say you should be able to hear air conduction twice as long. I don't know how they figure that out. If you tap it hard, it runs longer. So I would say instead that you should always note that air conduction is longer than bone. But as far as it being twice as long, I'm not that concerned. So you take your tuning fork, hold it at the node, and you tap it. Again, you're a machine now. Every time you tap it, it comes out exactly the same. So you tap that tuning fork, you're holding it at the node, and you go ahead and you take the single pole, spin it around, and touch it to their mastoid. And say, do you hear or feel a buzzing? And they go, yeah, I do. Say, tell me when that stops. As soon as they tell you it stopped, you take it off, swing it around, and move the fork side of the tuning fork to in front of their ear. And as long as you do the same, 4 inches, 6 inches, 2 inches, it doesn't really matter, just be the same. And they should always hear it better, again, because the air conduction up in front of the ear should be better than that bone. If they go, no, I don't hear it, still don't hear it, then there's something wrong, and the Rene test could be called positive. But they should hear it longer. Now they say twice as long, but like I say, if you're at 6 inches, 4 inches, does that make a difference if you hit it hard? So I don't know about that twice as long thing.